all of these scenarios are quite important. So suppose somebody does have an oligometastatic disease, one could consider just treating that oligometastatic site, and then let's say if they're amenable to surgical resection for a solitary brain tumor or radiation therapy in a focused way, and then continuing the targeted therapeutic approach. We've done that, and I think that's quite reasonable because only one portion of the tumor has built resistance. So if you take care of that in a certain way, the rest of the tumors may continue to respond. Whereas if you have a diffuse progression, but in a slow-growing way, do you continue with the targeted therapeutic approach? I think that's where we take a different approach, meaning if there's a clinical trial that's applicable to those patients, we consider that. And for a clinical trial, you would have to stop the previous therapy. If there's no clinical trial, but then potentially monitor them much more closely, and if there's frank progression, then to consider switching therapy. And then the third scenario is continuing to observe, and if there's frank progression, then to add on certain other therapies in combination with the previous therapy. I say that with a caution because I think you have to decide that at the time of the progression. And really, you have to have a frank discussion with patients to be able to say, well, this is what we're thinking, this is the data that's available, this is our clinical experience, and this is how we would approach it.